In August 2008, a journalist visited a hospital roughly 100 miles outside Harare. Hundreds of patients lay in overcrowded wards and on makeshift beds in hallways and waiting areas. Outside, hospital employees scrambled to pitch tents to accommodate the sick and dying still streaming in from the countryside. Doctors stood by helplessly, unable to do anything without the drugs and equipment they no longer had. They weren't facing a new epidemic. They weren't in a war zone. They were in the middle of an economic collapse so severe that a hospital, once described by The Lancet as one of the finest models of healthcare in the developing world, had become a place you went to die. This is Zimbabwe's mortality story, and the disease that killed the most people during the worst of it wasn't a virus. It was the economic collapse that made treating the virus impossible. Zimbabwe. Roughly 16 to 17 million people in southern Africa, bordered by South Africa to the south, Zambia to the north, Mozambique to the east, and Botswana to the west. Life expectancy today sits at 62.8 years, one of the most complex numbers in this entire series because of what it took to get there. At independence in 1980, Zimbabwe built a health system that was the envy of much of Africa. Strong community health infrastructure, good vaccination coverage, functioning hospitals. By 1990, life expectancy had reached 60 years, near the southern African average. Zimbabwe was a success story. Then HIV arrived, and the economic policies that followed made the epidemic catastrophic in a way it didn't have to be. HIV prevalence peaked at roughly 25% of the adult population in the late 1990s, one of the highest rates ever recorded anywhere. The health system that should have managed this was simultaneously being destroyed by hyperinflation. Hospitals ran out of supplies. Doctors were paid in currency that was worthless by the time they reached a shop to spend it. Most of them left. By the mid-2000s, life expectancy had collapsed to somewhere between 37 and 44 years, depending on the measure and the methodology, one of the sharpest peacetime reversals ever recorded for any country. It has since recovered. 62.8 years in 2023 is real. But to understand what Zimbabwe actually kills people with today, you have to understand how it got there. Before we go through the data, here's your true or false. Zimbabwe's life expectancy today has fully recovered to where it was before the economic collapse. The answer is largely true. And that's the most surprising part of Zimbabwe's story. Life expectancy in 2023 is 62.8 years. The pre-collapse peak was around 60 to 61 years in the early 1990s. By that crude metric, Zimbabwe has recovered, and then some. But what Zimbabwe is dying from now tells a more complicated story. HIV-related illness remains the largest cause of death among adults of reproductive age and children. In 2019, more than 40% of all deaths were attributed to HIV, lower respiratory infection, tuberculosis, and malaria combined. Non-communicable diseases now account for 31% of the disease burden, rising, as in every country this series has covered, but still behind the communicable category. In 2024, 31,800 children under 5 died. Zimbabwe holds the 5th highest HIV prevalence rate in the world, 14.3% of adults, down from 25% at the peak, but still a defining national health burden. And critically, as of 2018, 60% of AIDS-related deaths had declined since 2010, meaning the antiretroviral treatment program is working. The recovery from the collapse isn't over, but it's real. To understand why Zimbabwe's HIV epidemic became so lethal, you need to understand two timelines converging. The first is the biology. HIV was spreading rapidly through Zimbabwe's population from the mid-1980s. By 2000, 1 in 4 adults was living with the virus. We've covered HIV's biology in detail in our South Africa episode. The long silent infection, the immune system collapse, the opportunistic diseases that finally kill. None of that is unique to Zimbabwe. What was unique was the second timeline, when Robert Mugabe's government began its land reform program in 2000, seizing farms and redistributing them to political loyalists with no agricultural experience. Food production collapsed. Foreign investment fled. The government began printing money to cover its debts, producing the hyperinflation that by November 2008 reached an estimated 79.6 billion% monthly. Prices doubled roughly every 24 hours. A 100 trillion Zimbabwean dollar banknote couldn't pay for a bus fare. And inside this economic catastrophe, hospitals were being asked to function. They couldn't. Hospitals ran out of basic supplies. Doctors and nurses paid in currency that was worthless by the time they reached a shop, left the country in droves. Eventually, an estimated 3 to 4 million Zimbabweans out of a population of 12 million emigrated. A disproportionate number of them trained health workers. In 2008, only 25% of positions for doctors were filled in the state health system. Of those who remained, some were targeted by Mugabe's political militias for treating opposition supporters, effectively militarizing the decision of who received medical care. The 4 main hospitals in Harare stopped admitting patients. Pharmacies stood empty. Ambulances were grounded for want of fuel. The cholera epidemic that broke out in 2008 spread to 4 neighboring countries, eventually killing over 4,000 people. A disease entirely preventable by functioning sewage treatment, spread by a government that could no longer maintain its own water supply. When 1 in 4 adults is living with HIV, and the hospitals are empty of drugs and doctors, the HIV epidemic doesn't kill at the rate it should if treatment were available. It kills at the rate it does when there's nothing standing between the virus and its host. Zimbabwe's life expectancy didn't collapse because the HIV virus became more deadly. It collapsed because every system built to keep people alive stopped working at the same time. The recovery is as striking as the collapse. In April 2009, Zimbabwe abandoned its own currency entirely and adopted foreign currencies, primarily the US dollar, for daily transactions. Dollarization stabilized prices overnight. Within months, hospitals began receiving supplies again. The Zimbabwe health system, described in 2008 as on the verge of total collapse, began to function again. Simultaneously, antiretroviral therapy began scaling up rapidly, funded overwhelmingly by external donors, PEPFAR, the Global Fund, and international NGOs, rather than by a government that had no functional budget left. By 2016, life expectancy had recovered to 60 years. By 2023, it had reached 62.8, exceeding the pre-collapse peak. HIV prevalence has fallen from 25% to 14.3%. AIDS-related deaths fell 60% between 2010 and 2018. More than 1 million people were on antiretroviral treatment by 2018. The drugs that were absent from hospitals in 2008 are now reaching the people who need them, at a scale that would have seemed impossible during the darkest years. But here is what has not fully recovered, and may never fully recover. The economic conditions that enabled the collapse haven't been resolved. Zimbabwe experienced another bout of hyperinflation in 2019 to 2020, triggered by the same pattern of monetary mismanagement. As of 2013 to 2017, 72% of the population was living below the national poverty line. Today, the health system runs primarily on donor funding, not domestic investment. The brain drain continues, if at a less catastrophic pace than 2008. Underpaid skilled doctors are still leaving Zimbabwe for other countries. Hospitals are better equipped than in 2008, but still often below the standards of comparable African nations. Zimbabwe demonstrated something remarkable, that a health system can be destroyed in a decade and partly rebuilt in another. What it hasn't yet demonstrated is that it can be rebuilt sustainably without depending on the foreign funding that could always be reduced or redirected. If you watched our South Africa episode, You already know that both countries faced HIV epidemics of comparable severity in the same period. South Africa's HIV crisis produced a life expectancy collapse too, but not to the depths Zimbabwe experienced. The difference wasn't primarily about the virus. Both countries had similar HIV prevalence at the peak. The difference was about whether the health system survived. South Africa's economy was stable. Its hospitals remained functional, badly strained but operational. Treatment eventually reached people. Zimbabwe's economy destroyed its hospitals before treatment could reach anyone. The same pathogen had similar prevalence, producing wildly different mortality outcomes because one country's health system survived and one country's didn't. Zimbabwe's story is the clearest illustration this series has yet produced of what this channel keeps finding: the gap between the disease that should kill people and the disease that does kill people is always about systems, about whether a clinic is open, whether a doctor is in the building, whether the drug is on the shelf. Economic stability isn't a luxury separate from public health. It is public health. Next, we're beginning Phase 2 of the Death Atlas series, moving out of Africa and into the high-income countries, starting with the nation that spends more on healthcare per person than any other on Earth and still dies years younger than its peers.